Hi and welcome to Pharmacy Skills. In this video, I really want to do a massive deep dive into the direct acting anticoagulants, which is a huge part of the GPhC exam and something that you are required to know, not only just for the exam, but in your practice as well. Okay, let's start with a scenario. Imagine you're sitting at home watching TV and suddenly you notice your heart starts doing something weird. It starts beating in it's not beating in its usual steady rhythm. It's fluttering, skipping beats, almost like it's forgotten its own pattern. This is atrial fibrillation, and it happens to millions of people. Now, your heart fluttering may sound scary, but here's the real problem. When your heart doesn't beat properly, blood can start to collect in the corners and the chambers of the heart. And when the blood sits still for too long, it does something our bodies are absolutely brilliant at. It clots. Clotting is actually amazing when you need it, like when you cut your finger. Clots can save your life. But a clot forming in your heart, that clot can break free, travel up to your brain and cause a stroke. So we need to stop the clot from forming in the first place. And this is why we need anticoagulation, which is just preventing clots from forming when we don't want them to form. Let's zoom out for a second and talk about how clotting actually works, because understanding this makes everything else make sense. Imagine a row of dominoes standing in a line. When you cut yourself, the first domino tips over and starts the cascade. Each domino knocks over the next one, and then the next one, and then the next one, until finally at the very end, you get a stable clot made of something called fibrin. This whole process is called the clotting cascade, and it involves lots of different proteins, which here we will replace for dominoes, but these are called clotting factors. They all have numbers, things like factor 2, factor 10, and factor 8, and they all talk to each other in this very complicated chain reaction. Now, for decades, if you needed to prevent clots, you took a drug called warfarin. Warfarin works, but it's honestly a bit of a nightmare. It messes with multiple dominoes in that cascade, which sounds good, but the problem is it's unpredictable. Some days it works too well and you bleed, and some days it doesn't work enough and you're at risk of getting a clot. So you have to get your blood tested constantly and checking for something we call INR, which is basically a measure of how thin the blood is or how runny the blood is. You can't eat too much spinach or broccoli because the vitamin K in them interferes with the drug. And if you take antibiotics, your levels can go all over the place and it can get a little bit exhausting. So in the early 2000s, scientists had a thought: what if instead of interfering with the whole cascade, we just blocked one specific domino? What if we could design a drug that was so targeted and precise that it would be predictable, safe, and we wouldn't need constant blood tests? And that's exactly what they did. They created the direct acting oral anticoagulants. The word direct is important here. These drugs directly grab onto one specific domino or one specific clotting factor and stop it in its tracks. So without messing around with the whole entire system, just one clean target. There is 4 main drugs that we'll look at, starting with Dabigatran, which was the first one to be made. It works by blocking a clotting factor called thrombin, also known as factor 2. Thrombin is right near the end of the cascade. It's the domino that directly creates fibrin, the stuff that clots are made of. So if you block thrombin, you basically stop clots from forming. It's that simple. But then came a whole family of drugs that work slightly differently. Instead of blocking thrombin, they blocked a domino earlier than that in the chain called factor 10, or factor XA, X being the Roman numeral for 10. These drugs are called Apixaban, Rivaroxaban, and Edoxaban. Do you notice anything about those names? They all end in ban, and they all have XA hiding in there somewhere. Apixaban, Rivaroxaban, Edoxaban. They're all in the Xaban family. They block factor XA, which prevents the production of thrombin, which prevents clot formation. It's like stopping the cascade of dominoes one step earlier than the original Dabigatran. So now we have four main drugs: Dabigatran, the thrombin blocker, and the three Edoxabans. Each has its own personality, its own quirks, and understanding those quirks is what makes you confident when you see them in practice. Let's start with Dabigatran. Because it's the fussiest, Dabigatran is highly dependent on your kidneys. About 80% of the drug leaves your body through your kidneys, which means if your kidney function is not great, the drug builds up and you're at risk of bleeding. So with Dabigatran, we're always thinking about renal function. Always. There's another quirk though. Dabigatran comes in capsules that are really sensitive to moisture. You have to keep them in the original packaging, and you absolutely cannot open the capsule or crush it. It's a bit high maintenance, but it works when it works and used correctly. Now let's talk about Apixaban. Apixaban is probably the most forgiving of the bunch. It's less reliant on the kidneys than Dabigatran, which makes it the safer choice when someone's kidney function isn't perfect. It's taken twice a day, and here's the key detail. The dose depends on the rule of 3. If a patient has 2 out of 3 of the following: age over 80, weight under 60 kilograms, or a creatine level over 133, then you drop the dose from 5 milligrams twice a day down to 2.5 milligrams twice a day. It's very structured, a rule-based approach, and once you know the rule, it's straightforward. If they have 2 out of the 3, you would drop the dose. Rivaroxaban is next, and it has one very important quirk. If you're taking 15 milligrams or more, you have to take it with food. Food increases the absorption of Rivaroxaban, and without it, you wouldn't be getting the full dose. This is the only DOAC where food actually matters. The others, you can take them with or without food, but Rivaroxaban at high doses, always with food. It's also dosed once a day for most indications, which patients love because it's simple and straightforward. And finally, we have Edoxaban. Edoxaban is the newest of the 4, and it's also once daily. It's somewhere in the middle when it comes to kidney dependence. Not as extreme as Dabigatran, but you still need to think about renal function. The standard dose is 60 milligrams once a day, and you reduce it to 30 if the patient has kidney problems or weight less than 60 kilograms. So we've got 4 drugs, and they all do the same job. They prevent clots, but in slightly different ways with slightly different rules. Now let's talk about when we actually use them. The most common reason is atrial fibrillation. That's that irregular heartbeat we talked about at the start. If someone has atrial fibrillation and they are at risk of stroke, we give them DOACs to stop clots from forming in the heart. But there's one really important exception. If someone has a mechanical heart valve, DOACs do not work. They've been studied and they're not safe in those situations. This has something to do with the fact that they target only one specific factor in the clotting cascade, whereas with mechanical valves, the way they work and the way they exacerbate clotting, they require multiple stops in the cascade to be interfered with. And so for this, warfarin is better than using DOACs. So this is one absolute rule that you just have to remember for the exam. DOACs are also used to treat clots that have already formed. For example, in DVT, that is deep vein thrombosis in the legs, or pulmonary embolism in the lungs. Once the clot is treated, we often keep people on a DOAC long term to prevent it from happening again. And after certain surgeries as well, like a hip or knee replacement, we use DOACs to prevent clots from forming while patients are recovering. Now, even though DOACs are way more predictable than warfarin, they're not completely set it and forget it. You don't need to check INR levels, which is good, but you do need to keep an eye on the kidney function. Remember, all of these drugs rely on kidneys to some extent, especially Dabigatran. So at least once a year we check for renal function. If someone's kidney function drops, we might need to reduce the dose or even switch them to a different drug. Here's a really important point to remember. If someone's creatine clearance, basically a measure of their kidney function, drops below 15, DOACs are contraindicated. You can't use them, and if it's between 15 and 30, you're kind of in a gray zone and you need to be careful. Often you might need to refer to a specialist. That concludes part 1 on direct acting oral anticoagulants. Please stay tuned for part 2. So if you like this video and want to see more, want to see me break down more ideas, of course you can like and subscribe to this YouTube channel, but you can also just visit us at our home, www.pharmacyskills.com, where we have a large library of videos, resources, questions, live training sessions, and much more. We also have a WhatsApp group which you're welcome to join. Thank you very much for watching. I'll see you guys in the next one.